So, pressing questions, comments. Yep, go ahead.
I guess for us, one of the challenges we find is the content of the information that we're delivering to health work is not complex. It can be delivered in an appropriate way and it's knowledge at a level that people can take on. But it's exactly that issue that the health worker has their own remit and scope of practice, and so they don't have the resources and I guess the skill available to them to address those other issues and the elephants that are sitting in the room. And so are we talking about a concept of case management for complex care that is missing in these environments, that is outside the scope of the traditional role of the health worker? Where are these other issues? Who in the community is addressing these other issues? Are there case managers? Are there services that are dealing with these other things?
In New South Wales, with the Aboriginal Maternal Infant Health Service that Justine talked about, they provide antenatal care. It's an outreach model. It's a midwife and Aboriginal health worker working together. And the concept is that they do case management, and in many cases they are able to provide that degree of care. One of the problems comes that for smoking cessation, you actually need very intensive interventions and contact early in the pregnancy, but the standard structure for antenatal visits is that it's very infrequent early in the pregnancy, and so you get frequent visits later. So being able to have the flexibility to really address the complexities and do so early in the pregnancy, I think is, I don't know, Justine, do you think they really have the capacity to do that?
No. And even the way that the AMOSs were set up in New South Wales wasn't even based on the number of babies, Aboriginal babies born in that area. It was more about who applied and got funding. So they're struggling, I think, at the moment to even meet the demands of the number of women that are coming through the doors. And I think it's wonderful because there are more Aboriginal women using the service, but it means they have less and less capacity. And some of our Aboriginal health workers did try to do those extra follow-ups with phone calls and visits and things, but they don't have the capacity to provide the level of support required.
I think one of the real challenges, what we're talking about, is the support that can happen out of a community control service. And when you start to look at mainstream services, you just don't get the triaging and any of the level of support other than the visit.
Can I just say, I think, I agree that there's some fantastic services go around that do provide wraparound support, and a number of them, I was excited to see here today, like the Birthing in Our Communities program and the Punapima Cape One, and they are really great services. But the Centre of Perinatal Excellence did a survey last year and asked people the perinatal mental health mapping project, and the service providers that responded to that survey across Australia said that trauma and grief was the most significant thing that they were dealing with, 98%, and almost half of those people said that they didn't have the capacity within the services yet to deal specifically with trauma. So I think there is the care, the wraparound service, but we just need to develop some of that specialist expertise around how to provide safe care, how to have those sensitive discussions, how to actually provide that specific support, not just as it's complicated, but yeah.
In South Australia, in the Aboriginal Family Birthing Program, we've been able to use local Close the Gap funding to employ family support workers who work, and they're Aboriginal women and some men, who work in conjunction with social work and the rest of the multidisciplinary team. So that's one way to address some of these social determinants and the things that Kath's just been talking about.
I think in this afternoon's session, when we start to look at a range of questions, hopefully we'll be able to pick up on this and have people reporting back on it. And again, a reminder about the poster on barriers and enablers. any of your little sticky notes that you want to put up there, just as prompts for us to know what to follow up on.
I've just got a comment, like, it sounds like everyone's struggling, but remember in remote we're struggling worse because all those services that you have got, they don't even exist. So people are trying really hard to deliver everything, and it gets really almost impossible.
Yeah, and that's part of what we're trying to do with the, getting in to young kids to form good decisions, and pre-pregnancy is really an approach. Go.
I guess one of the things that is really striking me is that we're focusing. I mean, I know that this is a Indigenous smoking and pregnancy roundtable, so it's not surprising that we're talking about smoking cessation a lot. But I'm really wondering about whether we should be broadening the conversation to being about healthy pregnancies, because some work that I've been doing of late around alcohol and pregnancy is all the community people that I've been talking to, they don't just talk about alcohol, they'll talk about alcohol, drugs, smoking, and so they're not seeing it as one issue versus another. And I know that funding comes along, which is focused on one, like smoking. But it really strikes me as possibly a way forward to be, rather than talking about not smoking, it's about flipping the conversation. So it's about really promoting healthy pregnancies, and then maybe everything. I mean, I know everything is too much to be incorporated, but we can't address smoking and not alcohol, and we can't address smoking without addressing complex trauma and
those codependencies are recognised, and
I guess sorry, Tom.
Yeah,
sorry. Is that what we're talking about is our people, and it's everything that the person, the family, the communities do that will ensure healthy pregnancies and healthy babies.
And you'll see that in the questions for this afternoon's session, without labouring too much on those and getting too bogged down in tangents, because we are the Tackling Indigenous Smoking program, and that's our remit here and the sort of guidance we're after. But it's not suggesting that we don't recognise this, and as I said before, the rewrite of the implementation plan does pick that up. I might even pull up some slides later and just show you where we're at with that if time permits. Proceed.
Just quickly, I think as an example, probably just a consideration, I know in our area in the Shoalhaven and the Amos programs, talking about cultures and, referrals and that whole collaboration of service delivery. In our area, we don't have a high number of referrals coming out of the Amos program into our birth and on-country programs or any of our services. And often once you have that first point of contact at the hospital, there's a referral that goes to a place called Binjirimbora, which sounds like an Aboriginal organisation, but it's their local Amos program. A lot of women think they're getting referred to an Aboriginal organisation and don't realise it until much after. So I think that's just another consideration about how important it is to work together in collaboration and, case coordination and that collaboration, that we can have a more holistic approach together.
Thank you. Yes, now back over there.
Yeah, I already mentioned workforce. So one of the programs that we're rolling out is the maternal early childhood sustained home visiting, which should provide that kind of wraparound service, but it's about getting qualified clinicians to stay in community. And then with the programs like the Strong Women program, which is a Northern Territory program that MeWatch has transitioned for our region. So it's young senior women working alongside the clinicians with those women who are going through pregnancy. The problem is that you need those younger women to come up and be trained, because there's a whole generation of older AHPs and women working in that space who want to retire, and there's no one else ready to step into that space. So it becomes like really overwhelming for these people.
Okay, well, one last question down the front. First time at Healer.
Hi, my name's Brooke. I'm from ANFPP, and I think one of the things we find is that we're a bit of a wraparound service, but we refer out. So, but what we've found is that women don't necessarily want the uptake of that referral, and so making sure those referral agencies and networks that we're referring into and getting those specialist care, they need to work from that same frame. And one of the elements we've been building into our program is trauma-informed practice, and if those referral networks don't also work from that frame, it's really challenging to make sure that women are supported in the same way that they're supported within the context of our program.
And the new contract for NFPP is soon to change hands, and so it might be an opportune time for us, if we identify any issues, that we can pass on to the new contractor on issues that they might need to focus on it, or to the department they can pass it on to the contractor.